All right. Oh, never mind. Oh, one second. Let me grab my charger for my pad. Okay. Sorry about that, guys. So, yeah, with this scenario being kind of like finishing off the last session, I had to either A, make it um a new appointment on the scheduled space, Squarespace, and have you guys sign up for it, or just set it myself via Zoom and then just send you guys a link, which is why I kind of opted for the second option, because it's a lot easier on you guys. You don't have to do anything. I'm sending it to you guys. So it makes it a little bit easier. Do you still have all the options and tools that you usually have available to you outside of just being labeled as a guest? Okay. Okay, good. Good, good, good. All right then. So with that being said, what questions did you guys want to go over pertaining to this first 40 block? I'm going to do another 40 block before Monday, but this first 40 block, essentially, how'd you guys do? What questions did you have? What numbers were the questions? So I can go over those guys instead of having to go through the whole 40, because that's going to take forever, or not forever, but it's going to take time to go through all 40. So which question numbers did you have questions with? Any in particular things? Some of these may have been repeat questions because of me using just immuno block and kind of going through it. But with that being said, you should have been able to, been fine with those. This one here may have been confusing to you guys. Question 5 pertaining to this. Does it show which ones we got wrong? No, it doesn't show which ones got wrong, because that would have been, so if we would have done this on the day that it was due on Monday, then we would have been, yeah, I could have done it. But since I canceled it, I can't go back to see what the results of it were. So that's why I'm asking, which questions did you have issues with? Or I can just go through and choose ones that I can see were more complex than others, if there wasn't any particular number that you had questions with. Okay. So with that being said, let's go ahead and go through these. So, um, this one here, I think the next block, I'm gonna send you guys this 40 question like this as well, so you can write down your answers. Because I think what may have happened is you guys did them, and then you don't really know which questions you had issues with. You just know you had issues with it. Um, okay, so this one I can see as being something that was complex. So essentially, this is asking you, which of the following best explains this patient's hepatitis B virus status? So essentially, what's going on here in this individual is this person's positive for hepatitis B. Okay, so he has hepatitis B, but the results show that hepatitis B surface IgG antibody test is positive. And they're asking you what is to explain this process. Now, with this being said, this one here, we're going to break it down like this. This one here is set up like this. Whenever you have antibodies and antigens, this is something that's very important and something that I didn't really sit down and walk through, which is also why it's good that I gave these questions, that I didn't scan through them. These are questions that were literally just from Amboss, that were all immuno-based, because these are important concepts. So whenever you have antibodies and antigens together, right, these guys intermingle with one another, right? So for instance, what ends up happening is this. Some antibodies will bind antigens. Let me use blue. All right? Some antibodies bind antigens. However, at the very beginning of the disease, you got more antigens, more antigens than you do antibodies. Okay? So the ratio is higher antigens to lower antibodies. Does that make sense? Because your body's trying to catch up with infections. Now, as your body starts to catch up with the infection, you start increasing the antibody amount. Okay? So essentially what ends up happening now is you have, and this is something I'll post in the main group folder as well. So don't worry so much, more or less pay attention to what's going on. So if you have any questions, we can talk about it. So essentially what ends up happening is the antigen to antibody ratio essentially equals 1 at one point in time. 1 antigen to 1 antibody. Now, at this specific point in time, are you still infected with the bacteria or with this infection or disease? Yes, right? You still have the disease. However, when you look in the blood, are you going to see any antigens? At this specific point in time, would you see any antigens? No, because they've all been mopped up by the antibodies. This is a very big thing, okay? This is known as the window period. This is known as a window period because at this specific point in time, your body looks like you don't have a disease when you do. So this is termed the window period. And at this same point in time, that these antibodies that are binding these antigens are also 1-to-1. So are you going to find the antibodies in the blood at this point in time? No. Good. Because when you look in the blood, you're essentially looking at free antibodies and free antigens. You're never looking at antibody-antigen complexes when you're drawing blood. You're looking at free antibodies and free antigens. So at this point in time, not only will you have no antigens in the blood, but you also have no antibodies in the blood for the specified antigen. Okay? This is known as the window period. Now, this is the segue into you kicking the infection, because what's going to happen next is essentially the antibodies will overwhelm the antigens. And as a result, you'll see positive antibodies, but no antigen. This is the process of how you defeat or overcome diseases or sicknesses. Okay? So you always have the beginning period where you have high antigens and you don't notice any antibodies. No antibodies. However, as you start to kick the infection out, you start to then present with antibodies, no antigens in the blood. So here we have now resolved the infection. Now, this is not pertaining to IgG versus IgM. That's a whole different concept than this. Okay? This is just looking at what you will find in the blood at different points in time in an infection. Because essentially an infection is set up like this. You get an infection here at point 0, and essentially right at the beginning, you see high antigens. Antigens increase. And then antigens start to decrease as you resolve the infection. Now, on the other side of things, you have the corresponding antibodies, right? They don't start until late. So they then start to increase, antigens start to decrease, and then essentially you have this point where they intersect. This is known as the window period. Antigen and antibody are the same ratio, that at this particular point in time, you look like you don't have a disease, but you still have the disease. It's not until after you just see antigens, no antibodies, are you done with the illness, also known as resolved. Okay? Good. Any questions on that concept? Now, with that being said, that's that idea there. This here is talking about, once again, that same concept, but they're more or less just saying, and this is something you're going to go more in depth with in immuno, pertaining to passive immunity and how that presents. Because the answer is passive immunity. Because in this scenario, this here is IgG antibodies, and they're positive for it in a 2-month-old. So they're getting IgG, right, from the mother. So that's essentially why that is known as passive immunity. Okay. So that's explaining window period, while also talking about passive immunity, what the actual answer is. Now, if this was IgM, then I would say yes, the baby has an infection, be it either chronic or acute infection, right? Because the baby makes IgM, IgG can pass the placenta, like we discussed, if you remember. Here's our placenta. So if mom gets infected with a virus, she produces IgG, she produces IgM, she produces IgA. All these things are produced. However, IgM and IgA, as well as IgE, cannot pass the placenta, while IgG can. So baby then presents with IgG, which you are not able to say is active infection. You cannot say that because you don't know if the baby made the IgG or if it came from the mother. However, IgM is your big clue to say active infection. Okay? Yes. All right, good. Now, let's keep going. This one here may have been a little hard to understand, and the only reason why is because if you didn't know what CD95 was. Can anyone tell me what CD95 is? So CD95 is essentially the fast ligand. Yes, fast ligand stuff. Good. So, with that being said, this has to do with apoptosis, right? Now, where is fast ligand really needed? In one location. Okay? Because if you remember back in immuno, there's two ways that you can undergo apoptosis, right? One, it could be, this is extrinsically. One, it could be fast ligand related. Or two, it could be porphyrin related. This one here is the guy that's mainly utilized in the systemic system. This is mainly utilized in the thymus. Where in the thymus? This has to deal mainly with the, yes, perfect, the medulla. Negative selection is the big guy that this is utilized in. Now, does that mean that you don't see this in positive selection? No, you can, but you see it more in negative than in positive. Are they going to have both answers on a question? No. They're only going to have one of them. Okay. Either positive selection, because it's the same concept, or negative selection being the same concept, but it's more attached to negative selection. Okay. Good. So that's what's going on here. So as a result, if you don't have fast ligand killing apoptosis of lymphocytes, you get autoimmune cytopenia because now all of a sudden these negative selection guys are now in the system causing autoimmunity. Okay? So that's why that's the answer for this one. Autoimmune cytopenia. You see how like they take these concepts of immuno and they stack them on top of each other. So that's why it's really important that you get used and familiarize yourself with these, immuno concepts that we learned about at the beginning, which is also why I wanted to make sure I give you guys these 40 blocks towards the end. So when you start immuno, you've already kind of applied it really well. Okay. So with this one here, not really much is going on this question 7. This one is essentially getting at what type of explanation is this. And this is just a definition. It's literally just a definition. Now, when you go into your second cast, you're going to have a little bit of a better explanation and a better understanding of what a leukemoid reaction is. A leukemoid reaction is essentially just whenever you have an acute infection, not cancer. Okay. So you're going to walk through that process in cast 2, but this is related to immuno. So essentially what's going on here is this. You have these neutrophils and these band forms. Bands are really big clue for high levels of neutrophils being recruited. Can anyone tell me what interleukin this is? What interleukin would this be? IL-7 is big with stimulating the process of just survivability, right, of the bone marrow. IL-4 deals with IgE, IL-8. If you remember from macrophages, they produce all those acute phase reactants. IL-8 is one of them that deals with neutrophils. Okay, good. So you're going to stimulate that neutrophil recruitment. Okay. IL-7 is something that's more produced from Th1 and Th2 cells. All right, great. Okay, so let's continue. So that's why leukemoid reaction is also the answer here. Now, the other thing that's a big clue to let you know that this is a leukemoid reaction is this thing. Leukocyte alkaline phosphatase level. This is something that you only find when neutrophils are activated to kill infections. Okay. So this is also a big clue to make you think that this is a leukemoid reaction. All right, good. So let's continue. Let's see here what other big things. This one was just a granule thing. This one was pertaining to what they're most likely at risk for. So this was not a bad one. So here in this question, essentially you need to find out what this patient has, right? So the second they say this patient has increased risk for which of the following, if you remember those different classifications, one of those classifications was complications. Okay, so this is a complication question. So with that being said, you need to know what is the disease this person has. So this is a boy, comes in with intermittent abdominal cramps, recurrent episodes of foul-smelling, greasy diarrhea for 3 months. So this here is making you think that this patient has a parasite infection. Okay. Yes, giardiasis. Perfect. So with that being said, already you should start thinking that this disorder has to deal with B cells because parasites is a B cell ridden disease, right? However, we don't know if T cells are involved and this is a SCID, or a severe combined immunodeficiency. Now, let's continue. He also has history of recurrent upper respiratory infections. So once again, this is related to a type of B cell, not a virus, not a fungal. So no T cell involvement here. Then they ask that what is this patient most likely increased risk for? So this patient has a pure B cell issue. Now, there's a handful of pure B cell conditions. Can anyone name off a few? Pure B cell conditions. Maybe IgA deficiency? Right? What else? Okay, let's look back at this. Group session. And week 3. I know it's a long time ago, which is fine. These are your B cell pure things, pure B cell related conditions. Okay, so IgA deficiency, common variable immunodeficiency, and Brunton's agammaglobulinemia. Now, in Brunton's agammaglobulinemia and common variable immunodeficiencies, both of these guys, you lose all immunoglobulins. Okay? The only one you don't is selective IgA deficiency. In selective IgA deficiency, you only lose IgA. Now, how are you supposed to look at this scenario and differentiate that this isn't the other two? One, they don't give you a what is known as a what's that sucker called? Electrophoresis of the immunoglobulin. Okay, so they don't show you the electrophoresis of immunoglobulins, telling you things like what are the levels of IgA, what are the levels of IgG, and so on and so forth. So they don't tell you that. Okay. The other thing is look at the age of this patient. He's 5 years old, and he's just now having a lot more issues. If you were someone who had something like Brunton's agammaglobulinemia or common variable immunodeficiency, you have no immunoglobulins, you'd have more severe conditions. So much more severe, to the point that they would show up to you a lot younger than 5 years old. Because you're looking at it, you don't have any IgM, no IgG, none of those guys. So that's why that's the big issue. Now, with that being said, if you do not have IgA, this is something that you literally have to read through the disorder. You have increased risk for hypersensitivity reactions to transfusions. Now, the reason why that is this. If you don't have IgA and you get transfused blood, and this blood has IgA, your mast cells and your B cells do not recognize this as normal. So they target it and produce IgE, IgA antibodies. So you have a hypersensitivity type 1 reaction. Does that make sense? Now, what's your question you have about this one?
Yeah, yeah, that was basically what I was leading on to because I did positive elimination. I know B is more associated with H. pylori, disseminated tuberculosis that's out, cutaneous granuloma is out because we're looking at something that's GI related. So I couldn't. Other reason I didn't pick A because I was thinking like you, but I was thinking IgE solo. I didn't tie in the IgA association because I know if we lose B, we lose the ability to switch. I didn't count for IgA. That was because I was like, okay, I'm thinking IgE. So
Yeah.
that was my tie, and I missed.
Yeah. So that's why A here ends up being the answer for that one. Yep. So
Okay.
exactly, just like you were saying. So just make sure that you think, okay, there is one that just affects IgA. So all the other ones are normal. This is the most mild one of the three because essentially you don't have that many symptoms until later on. A lot of times people don't present with symptoms until they get blood. And then all of a sudden they have this reaction. A lot of times. That's how mild this condition is. Okay. So that's why I'm saying, at the grand scheme of things, this one is the most mild of the three. Okay.
Okay.
All right. Good. Now, this one here is, yeah, just more of a definition. So I'm not going to worry too much on that one. This one
Hold up,
here.
hold up, hold up, Doc. Hold up. Backtrack. This is the one that caught me
Okay.
because okay, I figured like this. If we're looking at a fracture, we're looking at a colony stimulating factor, something that stimulates repair. So
Okay.
automatically, I took out A, B, C, took those guys out because
Okay.
those are not stimulating factors.
Mm-hmm.
Uh, Now I picked D, but the answer was E. And
Yes.
I'm gonna tell you why I picked D. I picked D because usually GCSF stimulates TGF beta to come into play. So I was like, I couldn't make a connection with macrophage CSF.
Okay. So
But
GCSF does bring in TGF beta, but why?
uh, oh my god, I
The
got the
reason
mechanics.
why is because GCSF produces a whole bunch of different cells, one of
Mhm.
those being monocytes.
Yeah.
And
Okay.
monocytes can become M2 stage and then lead to TGF beta. That's way, and that's going to cause repair for regular tissues, not so much bone. You
Oh,
don't undergo fibrosis of bone.
that's right.
Does that make sense?
That does. Yes, sir.
Okay, perfect. So the reason why this is macrophage colony stimulating factor is because macrophage colony stimulating factor, what additional attribute this does is it stimulates the bone forming cells like osteoblasts, osteoclasts.
That's the missing link. Ah,
So it
okay.
stimulates these guys, which causes you to then be able to repair bone. Okay.
Thanks.
So you're not wrong with TGF beta. It's just that TGF beta is better for things like fibrosis.
Okay.
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 Good. Okay. Any questions other than that before we move on? Other than that, you did very great. It was just that one little detail, which you'll find as you go through questions, you'll run across those. Um, this one here, This cellular event is primarily induced by a molecule that is also responsible for which of the following changes. I want to say we did this question together, so I'm going to skip it already. This one we did not do. Yes, we did not do this one. So this is the big thing to go. So whenever you have a serum CH50, what essentially this is saying is this. This is testing the complement's ability to become activated and lyse red blood cells. Okay? That's what this CH50 is essentially doing. Seeing how well your complements can get activated and lyse red blood cells. So if it's low, that means you have a low amount of complement. Does that make sense?
Yeah.
Okay, perfect. Now, you do further workup and you see that it's C8 related because you already know that you have low complements, but you just don't know which one, right? It could be C1 through C9. I don't know. But you essentially find out later that it's C8 related. C8 is only related to the MAC, right? So as a result, the big guy that can get affected here is Neisseria species. Because once again, gram-negative bacteria.
Yeah. That's true.
Okay. All right, good. But this right here is the one thing that I want to say I didn't go over, but is important to know is what CH50SA is. That's how you test to see the complement level. Okay.
Because I did look at that and I saw it as T8 was complement, so I knew it wouldn't be a gram positive answer. It has to be something related to gram negative.
Oh, okay. Yeah, it works out. Just
Okay.
just in case if they don't, because they essentially could not even like they could have left this out
Okay. Oh,
and just
okay.
said you that CH50SA shows inappropriate low erythrocyte lyse. Which one of these is he most likely to get recurrent infections of?
Okay.
Okay. Um Now, with that being said, there's two different ways that you can get low complement. One is via this guy, which is terminal, right? Deficiency. And the other one is early complement. Now, remember, early complement has to deal with having increased um antigen complexes, antigen antibody complexes. Because C3B is important for opsonizing these guys and getting them out of the blood. Okay. This one I want to say we did together. This one we did not do together. So in this scenario, it's asking you which of the following is the best describes pathogenesis. So in this individual, we have da 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 da. Wait, no, we did do this one. Never mind. We did this one already. Because this is that type 2 hypersensitivity reaction. This is myasthenia gravis. Okay. This one here. So it's Graham. Yes, this one we didn't do together. Does anyone have any questions on this one? 15. Because this is essentially looking at the process
Uh,
of infection. What?
oh no, no. Once I saw Astrophagous bacillus, I started thinking mycoplasma,
Yeah,
and
Mike
that's
TB. Okay.
yes, yes.
Yeah.
So I was trying to see what's in here will incorporate that. Like as far as how would we treat it as far as making the what's that? Not the giant cell, the granuloma and stuff like that.
Yeah.
But
So
I know it's internal in the lungs, so it's alveolar macrophages.
yes. So alveolar macrophages are in the lungs. Good. That's great. So did you choose C?
I think I did.
Okay. So essentially, what they're getting at and what they're asking you is this: what is the process of infection if the bacteria is not killed off by the macrophage, right? So
Yeah.
with TB or any of the other guys that can escape the phagolysosome, they get inside the macrophage and they replicate inside the macrophage. Okay? So fusion of phagolysosomes and neutrophils never occurs because this is something that stays within the bacteria, or no, stays within the macrophage. So that's out. Production of interferon gamma and helper T cells. This is something that happens, but that's after this macrophage has traveled to the lymph node and activates CD4 cells to become Th1. Okay. And then they come back to the site of infection, releasing interferon gamma. Okay. So essentially, this is too far down the line because this is asking you for the first thing that occurred. Okay. And the first thing that occurred is that these macrophages have it replicating inside of them. Now, what they don't have here is the what they don't have here is the avoidance in macrophages. And if they had that, that essentially would have been number one. So that would have been the answer if they had that in the answer choices instead of this. Okay? Because that's what they do first. They first avoid or they get out of that phagolysosome, get inside the cytoplasm, replicate in the cytoplasm. It travels to the lymph node, activates these guys. They come back, releasing interferon gamma. These guys then get activated. They then start releasing TNF alpha to propagate the process of increasing macrophages to the location, which then leads to our lovely caseating granuloma.
Loma. That's correct. Okay.
Okay. So this is almost a tie together between immuno and path. Now, let's continue. So this one here, I want to say we went over because this is dealing with polycystic kidney disease and with transplantation. So I'm not going to harp too much on this one, unless you have questions, of course. This one here, it's the same concept with skin grafts. This is a good one. So in this scenario, what's going on here is what is known as lupus, because they're asking you detection of antibodies directed against which of the following is most specific for this patient's condition. So this is basically a pathogenesis question, right? Those categories that we discussed. This is a pathogenesis question. So we need to know the disease. So this patient presents with sunburn areas of the skin and arms. She's usually fatigued. Okay. She has bilateral swelling and tenderness of the wrists at the metacarpophalangeal joints, multiple non-tender superficial ulcers. This is the presentation of lupus. Lupus presents with things like joint swelling, joint pain. They get a malar rash, which is the rash around the cheeks underneath the eyes. You present also with ulcers in the mouth, which is another big thing. All right. So This is the presentation. Now, this isn't all those symptoms. You also have antibodies produced against your phospholipid bilayer. That's the phospholipid coagulative disease, which you'll do later. But the big thing here is what are you going to find in this person's blood, right? Detection of which antibody. Yes. Mm-hmm. That's the photosensitivity. Now, photosensitivity, since you asked me that question, photosensitivity is only done essentially by three different things. One, lupus. Two, xeroderma pigmentosum. Three is a heme pathway. Okay, this is a protoporphyria. To be exact about it, it's porphyria cutanea tarda, PCT. Porphyria cutanea tarda. It's the last one. Okay, not acute intermittent porphyria. Porphyria cutanea tarda, because acute intermittent porphyria is the one that presents with abdominal pain. They're psychotic. They have psych symptoms. Their urine looks different colored. That's that presentation. Okay. But these are the three things that you'll present with photosensitivity: lupus, xeroderma pigmentosum, which has to do with the nucleotide excision repair stuff, right? And protoporphyria, the porphyria cutanea tarda one. All right. Good. Now, with that being said, this one here ends up being the production of this anti-smooth muscle, or anti-Smith, my bad, anti-Smith proteins, which is, once again, just a flat understanding of what lupus is. Okay. You will go over lupus more in depth when you do autoimmunity in your lectures. I didn't really sit there and go through it all the way because those are the guys that's literally just definition. It's either you just got to know the symptoms that go with them. Okay, so let's move on. So this one here, 19. This one I want to say, yeah, we've gone over this because this is a fungus. Funguses need IgE related substances, which is why this is E for that one. This one here, let me see here. Okay, yeah, this is a good one. So she was given a non-conjugated routine childhood vaccine, non-infectious glycoprotein, and they're asking you, this vaccine is which category of vaccine? Which category? Is it a subunit? Is it a conjugated, an inactivated, a live attenuated, a passive immunization? So a live attenuated would be something that is the same virus, but has been decreased in infectivity. That's not what's going on here, because this is a non-infectious thing. Okay. Now, inactivated or killed. Now, with that aspect of it, they've actually made the protein itself dead. Okay. Excuse me. With that, you don't need to conjugate it to anything because it's already a protein. Okay. Now, however, you do not vaccinate any newborns with an inactivated killed vaccine. There's no newborn you vaccinate with an inactivated vaccine. Conjugated, that contradicts this concept. So the answer here is subunit. This is essentially the hepatitis vaccine, hepatitis B, that you do give to newborns when they're delivered. You give them the Hep B vaccine. Yes. Okay, good. So you don't have to remember this portion of it. That's something that you'll get as you go. But these breakdowns of vaccines, you do have to know. All right, this one here, yeah, it's not really that hard, or not, I won't say hard, but it wasn't something that we didn't go over. Oh, you know what? Kind of. This is talking about methotrexate. So this is a side effect question / mechanism of action whenever you do farm, right? So this is specifically looking at mechanism of action for methotrexate. So it's literally you know it or you don't. And that's B. Yep. This one here, they're asking for the increased susceptibility to infection. What is he most likely of getting? Due to which of the following? So this one here is an individual. This is one that we went over, but I had removed key details that gave you the answer when we went over it the last time. So now you have to actually diagnose the patient. So in this example, it's a kid. He's getting a lot of rashes. Okay. They're not improving with topical corticosteroids. Okay. He has abscesses that are asymptomatic. Asymptomatic abscesses mean these are cold abscesses. The reason why I say that is this is because if you normally have an abscess, think of this in like your past experiences, right? If you normally have an abscess, what is it? It's warm, it's hot, it's painful, right? This is none of that. He has abscesses on his body that are asymptomatic. So that is known as a cold abscess. And there's only one disease or disorder that deals with that, which is Job's. Okay. Now, let's continue though. Okay. He's having pneumonia. Okay, so we're thinking this has to be kind of going towards maybe a B cell related condition, but he has right plaque, so fungal. So this is more T cell related condition. So with this being a more T cell related condition, we start thinking about what are the T cell guys. So the T cell guys, we know this isn't a severe combined immunodeficiency because there's no parasite, no diarrhea. So this has to be a T cell related. Okay. So with that being said, you look at the T cell related conditions, which hopefully you got down. And Job is one of them. Boop. So that's your answer. Okay. You see how that, like, that's how you have to attack these questions. Okay. You have to attack it in that manner. You have to read through them like cold abscesses. That was a clue that made me think, oh, this is most likely Job's. Now it's T cell related. Job's a T cell related condition. This is most likely Job's. Now, with that being said, the answer for this then is impaired chemotaxis of neutrophils because we have TH17 being the big player here. All right, in Job's. So let's continue. This one here, FOXP3, yeah, not really going to harp too much on that one. We went over that. This one here, yes, we went over this one as well. Carfilizumab therapy. So this here is looking at, once again, immunopharm, and they're asking you what is the function of carfilizumab. Carfilizumab is a protease inhibitor. Okay. Now, with carfilizumab being a protease inhibitor or proteasome inhibitor, yeah, it's proteasome, protease type thing. You're decreasing protein breakdown. Okay. So if you're decreasing protein breakdown, you're then going to cause increased levels of everything else. So, with that being said, you then present with things such as, excuse me, such as increased production of proteins, right? Because they're not getting degraded. So things like, because the answer here ends up being C, things like pro-apoptosis and the ability to break down endogenous proteins via the MHC1 pathway. So if you can't break down things via the endogenous pathway, because that uses the proteasome to break those things down into proteins and present them on MHC1s, CD8s don't work properly because you're not presenting any endogenous proteins anymore. Yeah, like you also have that ability as well. You have you can't recycle proteins needed for replication. You can't break down proteins to form new proteins. All those also play a part as well. Yep. Okay, good. So let's move on. Okay. Let's see here. All right. What I'll do is I will send the rest of this to you because I think what may have happened is you guys may have ran across questions that you were confused with, but don't have any way of recollecting what number. Um, so we can then get on to the next thing because I don't want to harp too much on this. Okay. Now, with that being said, I'll do the same thing with I'll do the same thing with the coming Socrative. So you could do it that way. I'm trying to think what you know what I'm going to do a little differently. What I'm going to do is I'm going to send you guys the Word document like this, and then I'm going to send you on Monday. I'll no, and I'll also send out the answer one, the answer document like this. So you'll have the question numbers and the answer documents together so you can look at them and not have to worry about did I miss this one? Did I not miss this one? Did I understand this one? Which question number was it? You'll have it all available to you. Okay, good. That's what I'm going to do for this next one that you guys will get on Saturday tomorrow. All right. Any questions on any of that? Boop. No. Good. All right. Let's take like a 5-minute break. We'll come back at let's do 6:10. We'll come back at 6:10. Okay. And then at 6:10, we'll come back together and we'll plow through the rest of path and we'll be done for today. All right, guys. So let's go ahead and get started with the old stuff. All right, so this is the questions that we did not get through. I hope you have finished going over them with the form that I had sent out to everyone earlier. So with this one, I'm just going to kind of walk through and kind of talk about what's going on. So essentially here we have an individual who has a burn, hot water, and is a 3-year-old. And now they're looking at wound contraction develops. And they're asking you which is the guy is responsible for this. That ends up being the myofibroblast, right? Now, my question to you now is what day do myofibroblasts start to produce and present themselves? What day? Oh, okay. What's so good? I didn't pause. Yeah, good. So around 3 to 10 days. So 7 is fine, but essentially it's around 3 to 10 days. Okay. So it's after the acute phase has occurred. And during this 3 to 10 days, you have granulation tissue being developed here. And we are essentially getting everything to go. Now, myofibroblasts are stimulated by what factor? What stimulates myofibroblast? Or better yet, what stimulates fibroblasts to become myofibroblasts? Okay, good. Yeah, IGF or TGF beta. Good stuff. Nice, nice, nice. So you may see it as either one of these guys. Okay. Yeah, let's keep going. Now, after these guys get activated, what do they release? What do fibroblasts release? What do they produce? They produce type 3 collagen, right? And type 3 collagen then becomes type 1 weeks later. Okay, good. Any questions on any of that before we move on? Okay, good stuff. So this stuff we already discussed. Now, here, this has to deal with most likely contributed to the patient's decreased arm size. So basically, it's asking why did the patient's arm decrease? Well, there's two different ways for the cell or for an organ to decrease. Yes, if you don't use it, you lose it. Perfect. One is atrophy, right? And the second option that has to deal with this process is if you have hypoplasia. Now, hypoplasia is just the aspect of incomplete organ or structured development. Okay. So, for instance, the mandible doesn't fully develop properly in people who have um what is that condition called? DeGeorge. DeGeorge. Okay. So in those conditions, they have hypoplasia. It's there, but it's not a full mandible like a normal person of that age. Okay. Now, a genesis is something different. A genesis is the lack of the organ. So, for instance, I could have a lack of a limb, like no limb would develop. Okay. And you see that in individuals who have things like um the mermaid syndrome. I can't think of the name of it right now, but it's the mermaid syndrome that they don't have both legs. They only have one leg, but it's because both legs are fused into one. So that would be a type of agenesis. They're missing a limb. Okay. Or renal agenesis, lung agenesis, like you discussed. Yeah, cyanomelia. That's a condition. Yep, exactly. Um, I I was gonna say syringomyelia, but I was like, syringomyelia is not it. Syringomyelia has to do with the spinal cord, not the limbs. But I knew it was like mermaid condition around those like, yep, siren, yep, perfect. Um, so yeah, let's keep going. So we discussed that. And with that being said, atrophy. Okay, so atrophy, you can have two different ways of atrophy. You can have it because of ischemia, right? The lack of blood supply to an organ causes the organ to atrophy. Okay. This is an example of people who get atherosclerosis of the peripheral vascular system, also known as peripheral vascular disease. Okay. What happens is the muscles in those extremities atrophy, they get smaller, not because of disuse. They're using the organ, they're using that organ. It's because of lack of nutrients, ischemia. Okay. So ischemia is one way, and the other way is due to, just like you guys said, usage. Okay. So here in this scenario, they tell you this. This is why they tell you this. Pulse is strong and blood flow to the hands and fingers are good. So you know it's not due to ischemia. So this must be due to usage issues. Now, within the usage issue, it could be a variety of things. One, it could be the neuron. If you remember back in year one, you have lower motor neurons and upper motor neurons. Lower motor neurons, you get atrophy. Okay. Or it could be due to the actual muscle itself. Okay. Now, how do you know it's not deinnervation? The reason why is because in this scenario, they do not talk about any other lower motor neuron signs. They don't tell you the patient has hyporeflexia. They don't tell you that this patient has spasticity, right? They don't tell you any of that stuff. No, fasciculations. Fasciculations is what I was thinking. Fasciculations. They don't tell you any of those things. So with that being said, this cannot be A. It has to be due to B. Just regular disuse of the muscle. Okay? Does that make sense? Any questions on that?
So I did want to correct myself from earlier. I did mention like the lungs via renal agenesis, but I meant to say Potter syndrome, where you see hypoplasia of the lungs, pulmonary hypoplasia. That's what I
Yes.
meant to mention.
Oh,
Sorry.
okay. So Potter syndrome. Okay, perfect. So with pulmonary hyperplasia, yes, that would be a great example of hyperplasia. Would be that particular portion of the lungs. Yes, I do agree. I do agree. Great job. Okay. Let's continue. Okay, so we talked about atrophy. You have that in there. We talked about the disuse aspect of things. Here's the atrophy stuff: lack of a stimulation, lack of blood supply, the nutrient aspect of things. Okay, here, this is not the right answer. The right answer is E. So here is an individual, and essentially they're showing you this picture. Now, you see this person has, okay, presumed he had a viral infection, did not seek treatment. 3 days ago, he had it. Today, he developed a rash on his lower legs. There's numbness, tingling, and burning sensation over his left hand and left wrist and hand. Okay. All right. All right. Now, my thing is this that I want to talk to you about. Remember back in immuno when we talked about this today. Now, at this point in time, you have what? A lot of antibodies bound to antigens, right? Good. What is that called? Antibodies bound to antigens. Don't give me the period. Yes, that's the length of time called the window period when you don't present with any antibodies or antigens. But what is the term given to something when you have antibodies and antigens bound to each other? It's called an immune complex. Yes. Now, when you have immune complexes, what can happen? They can get deposited in various tissues, causing type 3 hypersensitivity reactions. This is a symptom you can present with infections because of this concept. At this window period, post-infection, but not fully resolved, just like in this scenario, he's 3 days post-infection. So he has immune complexes floating around in the body. They deposit in the tissues like veins, or not veins, arteries, causing vasculitis. They deposit in the kidneys, causing nephritis. They deposit in the joints, causing arthritis. Now, when they deposit in the vascular system, they present as this. This is known as fibrinoid necrosis. Essentially, what fibrinoid necrosis is talking about is the aspect of proteins being deposited on the vascular walls, activating complement, causing cell death. Because that's what necrosis is. cell death. So that's what fibrinoid necrosis is. Does that make sense? VNA. I don't know what VNA is. What is VNA? Oh, yes. Vasculitis, nephritis, arthritis. Yep. Okay, great. So you can see here, immune complex deposition, type 3. Okay? Causes fibrinoid necrosis because of what we discussed. It's the vasculitis part. So this is tying in again, immuno and path. You already know what type 3 hypersensitivity is. Now, all they're saying is if you do a biopsy of it, you see fibrinoid necrosis. Okay? Good. Okay, great. Now, let's continue. Here is a scenario where they're talking about a person's prostate gland, they're comparing it to the normal prostate, and they're asking which one of these guys below most likely matches what is going on in this man's prostate. Okay, so if you remember back when you did repro, an older man over time, the prostate gets bigger. Now, when you did anatomy, you should have talked about what part of the prostate gets bigger. Can anyone tell me what part? What zone? Yes, the medial. Okay. So, yeah. So you got this medial portion or this medial lobe that gets affected. Yes, exactly. For BPH. Exactly. Great. Now, the peripheral lobe is for more cancers of the prostate. Great. Great, great, great. Now, with this being this medial lobe, you have this division, you have this hypertrophy that's going on that's non-cancerous, okay? Because they tell you that this patient has he's urinating a lot, there's no asymmetry or no nodules noted, so there's nothing that makes you think that this patient has cancer. This is something that's non-cancerous. So this is due to hypertrophy. Now, in hypertrophy of the prostate, you deal with increasing the number of gland cells, increasing proteins, increasing DNA because it undergoes hyperplasia. Okay? So that's why this ends up being A. Now, here is the different breakdowns that we talked about, right? So here, with the first one being increased stress or leads to increased organ size. Now, this increased stress could also be increased endocrine hormone, leading to increased organ size, right? So either one of those could be the same corresponding factor. Now, with that being said, here we talk about BPH because BPH is different than something like endometrial hyperplasia. Okay? Because endometrial hyperplasia is cancerous, because usually hyperplasia is related to cancer, but in BPH, it's not related to cancer. It's due to the rapid proliferation that then there causes BPH. Okay? Any questions on that? And you can see produces new cells. And these new cells have more proteins. That means you have more cells. That means you have more DNA, which is why A is the answer. Okay. And let's keep going. Now, this one here is just asking you, excuse me, this one here is just asking you, so based on analysis, which of the following is most likely contributed to the change in the neutrophils from day 1 to day 14? Well, what has happened? So on day 1, we have abundant neutrophils, and they're no longer present on day 14. So that means they died. How do neutrophils die? Via, they liquefy, yes, but they undergo apoptosis. Right? Because there's two ways that you can die. One is apoptosis, the other is necrosis. Necrosis is only pathogenic. So that's why D is not the right answer to this. And back is decreased. That would actually be pro survival. Excess BCL2 also pro survival. Backs being increased leads to apoptosis from the intrinsic pathway. Okay? Now, this one here, it's asking this woman's immune response was triggered by interaction between a bacterial cell wall component and which of the following? Excuse me. So, what's going on here? We have sweat and chills 3 days ago, urinary frequency, antibiotics. She woke up. She has some urinary infection going on. She has gram-negative rods. And then they're asking what part of these gram-negative rods activated the immune response. LPS. Perfect. LPS. It could be the O antigen part of the LPS. It could be the actual LPS itself that binds to CD14. And membrane proteins is the answer. Okay. Just like we said, LPS. Oh, here's the next question. CD14 gets activated. What's the secondary messenger that gets activated? Let's see how much immunome you can recall. So if CD14 gets activated, there's a secondary messenger inside the cell that gets activated. What is it? Almost like how cyclic AMP is activated with alpha S or GS pathway. What is it with CD14? Yes, good. NF kappa beta. Good, good, good. So that's what's going on here. And then this then causes the upregulation of all our lovely guys, IL-1, IL-6, IL-8, IL-12, and TNF alpha. Okay? Good. All right. So now, here's the next one. This is talking about which of the following processes is occurring in the wound at this time. So we need to know a time span. 1 week. 1 week ago, recovered. She denies. 5 centimeter lesion is dry, clean, dry, and intact. Minimal redness at the edges of the wound. And they're asking you which is going on. Angiogenesis. The redness in the wound is due to angiogenesis. Production of new RBCs. Now, yes, this is the granulation period. Correct. You do have granulation tissue going on. Yep. You have the myofibroblasts at this point in time. You have fibroblasts at this time. High levels of TGF beta at this time and IGF beta. But this is the big one. You have angiogenesis occurring at this time. What is the big player that deals with angiogenesis? What stimulates angiogenesis? You should tell me two things. So one is fibroblast growth factor. Fibroblast growth factor stimulates angiogenesis at this location, which is controversy because fibroblast growth factor doesn't sound like it would do anything with angiogenesis. This is the one they tend to throw at you a lot. Okay. And yes, VEGF is also a big one that deals with it as well. Vascular endothelial growth factor. And then I guess additional one we could say is platelet-derived growth factor. These two are the big things inside of a wound. Okay. The VEGF really comes into play whenever you get hypoxia. Now, you could be sitting here and saying, but there's hypoxia going on here because you've ruptured blood vessels. And now all of a sudden the blood is just there in the tissues and it's not moving about like it's supposed to. No, not necessarily. And the reason why I say that is because of this. One, the blood is located here, right? So if blood just pools at a location, you got RBCs still releasing oxygen. Two, more blood can come in, and blood also leaves and gets degraded by macrophages. So you're constantly replenishing oxygen to the tissue. Okay? So as a result, it allows you to not so much do VEGF. I mean, you do a little bit of VEGF. I'm not saying you don't, but these are the big ones: fibroblast growth factor and platelet-derived growth factor. When it comes to the tissue and injuries, like trauma and stuff like that. Now, that means this also. If you have blockage of blood, like someone who has peripheral vascular disease, like in diabetes, you have a decrease in blood to areas that are damaged. That means you got less platelets coming into the tissue. Less platelets means less of these guys. Less of these guys means less wound healing. That's the issue with people who are diabetic with peripheral vascular disease. Okay? So, with that being said, having good blood supply is a must. Remember that. Having good blood supply is a must when you are undergoing wound healing. If you do not have good blood supply, you will not have good healing. Okay? All right, good. Let's continue. And yep, we talked about all this stuff, so I'm not going to harp on it anymore. Here, we're talking more about which of the following cell types is most likely to be found in the affected joints. So, this is an individual who has stiffness. So this is an example of someone who has something known as rheumatoid arthritis. Okay. Now, in rheumatoid arthritis, you get this type of presentation. Swelling and tenderness over the PIP joints. Okay. These guys right here. PIPs. It's usually the PIPs and then the MCPs, as well as the wrist. These are the locations for rheumatoid arthritis. You will talk more about this in your second cast because you go over, no, your second? Yeah. Because you do HEMONC and MSK together. So you're talking about these guys in your second cast, okay, with rheumatoid arthritis. Now, with that being said, whenever you get rheumatoid arthritis, you have various antibodies being activated. It's an autoimmune disease. Okay? And these antibodies, they bind to various things and they form immune complexes. Okay? Now, as a result of forming immune complexes, these guys, macrophages, are responsible for clearing them up, which is why they show up in the affected joints. Okay? Any questions on that? Okay, good. Now, here it's talking about an individual who essentially ends up having what is known as pancreatitis. Now, I'm trying to see here. This here is very big to know for pancreatitis. Okay? Now, with the pancreas being irritated, enzymes get pushed out. When enzymes, I wouldn't say macrophages are devouring healthy tissue because you have those immune complexes there. So they're trying to devour the immune complexes that are stuck in the tissue. As well as rheumatoid arthritis is also a chronic condition. So in chronic conditions, you get macrophages also. So those are the two reasons why macrophages are present. One is due to it being a chronic condition. The other one being that you have immune complexes there that are trying to clean up or that are being cleaned up by macrophages. But yeah, I mean, you got to think when a macrophage gets activated, he releases his contents, which is inflammatory contents. IL-1, IL-6, IL-8, IL-12, TNF alpha. So that causes damage to the cells around them. Okay. Yeah. Yep. Okay. Good. Now, here we have pancreatitis. And pancreatitis, you have enzymes released. These enzymes break down fat. Okay. Now, whenever fat gets damaged, what can happen regarding calcium? What can happen with regard to calcium? I know it's been a while, but we discussed it. Yeah, fat binds with calcium. Perfect. So fat binds with calcium via some process known as lipolysis. Okay. Now, this process is essentially free fatty acids plus calcium, which presents as calcifications. We're going to talk a little bit more about that when I go over that PowerPoint slide. So that's why this is fat necrosis. There's only two main locations you get fat necrosis. One, breast. Two, pancreas. Now, why breast? Trauma. You get breast trauma, a woman gets punched in the breast, or she ends up accidentally falling on her breast, something along those lines that causes trauma. There's a lot of fat tissue located in the breast, and that allows the triglycerides to be released. Fatty acids get activated, they get calcified, and they present as fat necrosis in the breast and then pancreas we talked about. Those are the two locations that you mainly present with fat necrosis. Okay? Breast, pancreas. Nowhere else. Okay? Good. Let's continue. Now, here is asking about this assembly most likely leads to cellular release of which of the following. So essentially, what cytokine is going to be released by some component. So this component is uric acid. If you remember back in immuno, there's two different ways that you can activate macrophages. No, really three different ways. Okay? One, you can have an infection. Right? These guys activate macrophages to become M1. Second thing that can happen, tissue damage. Can go to the macrophages and activate macrophages. The last one is what is known as crystals, like uric crystals, urate crystals. They activate macrophages and they become activated. So my next question is this. Now that I have reminded you of these ways, tell me how step 2 and step 3 is different than step 1. How are they different? Tissue damage and crystals use a certain intracellular, I guess, protein, you could say. Intracellular signal, I would say, more than anything. What's the signal that tissue damage and crystals use? Do you remember? They poke them, and then these macrophages get mad via the inflammasomes. And these inflammasomes, they get activated and they produce IL-1. And IL-1 is the guy that deals with the inflammation. So that's why C is the answer in this one. Okay? So don't forget tissue damage and crystals, inflammasomes. Infection is the one you already know. Toll-like receptors, CD14, LPS, NF-kappa beta, all that stuff. Okay? Via tissue damage and crystals activating inflammasomes, leading to M0 being activated in M1, and M1 deals with this stuff. Back to Anki. Yeah, I mean, Anki's not bad, right? But make sure you have the good understanding, right? So you can make those connections. That Anki can then just plow into your brain to make you remember it. But yeah, okay, good. So that's why this one is C. Okay. All right, let's continue. Here, we're talking about retinoblastoma. Retinoblastoma is responsible for what portion of the cell cycle? Right? You have G1, you have S, you have G2, you have M, and you even have G0. And it goes like this. Whoop. And then this can come back into as needed. So, where is retinoblastoma located at? Retinoblastoma is located right here. He's noted between G1 and S. That's where he's located at. Okay? Now, with that being said, retinoblastoma, when he's activated, he gets hyperphosphorylated. He removes himself, allowing you to release the production of DNA polymerases for S phase. Okay? Now, let's continue. If you were to, let's see here, drug X, known to activate cyclin-dependent kinase 4, this is a guy that hyperphosphorylates retinoblastoma. 4 and 6 is noted in G1. 4 being the one that deals with retinoblastoma. Then they want you to know now what's going to happen an hour later. You're going to have S phase because you're going to hyperphosphorylate retinoblastoma. Retinoblastoma is going to leave. You're going to have EF2 being moved along to allow S phase to undergo. Okay? Any questions on that? Yes, retinoblastoma is the checkpoint. You are correct. Okay. Let's continue. So, here you see it with retinoblastoma. I think I said EF2, did I? Or E? Oh, I meant E2F, my bad. E2F. Tell you, sometimes my dyslexia comes and gets me in the butt. So E2F, not EF2. So E2F, but this is a guy, once again, he gets hyperphosphorylated and allows retinoblastoma to then do its thing because retinoblastoma becomes hyperphosphorylated, so it leaves. So EF2 can come down, undergo gene transcription into S phase. Okay? And that's the process that goes on. All right. Now, let's see here. How many questions we got left? Oh, okay, we don't have that many left. You want to do 4 minutes and then we'll come back and finish off the rest, and then we'll do the rest of this PowerPoint. Sound good? So we'll give you about 3 minutes and then we'll finish off this PowerPoint because essentially I've gone over all of these guys. I just got to talk about them a little bit more in depth. Like all these guys we've already talked about. Talked about this too. So I don't think we're going to be any more than 30 minutes. But let's take a little break because it's been an hour. So let's take a little break, come back, 7, finish everything off. All right. Okay. Let's continue with what we were going over. So we finished this question, and now we're on this question that basically it breaks down this presentation. Eosinophilic degeneration of hepatocytes with condensed nuclear chromatin. Whenever you have condensed nuclear chromatin, that's essentially saying that a condition known as pycnosis is occurring. Pycnosis is whenever the nucleus gets very small, right before the nucleus starts to break apart and dissolve away. Okay? So, with that being said, what do you think would cause a nucleus to get smaller, right? It'd be apoptosis. If you were just killing the cell off without any forewarning, the nucleus would never be able to condense down. It would just die. Okay? So that's why you do not see that in necrosis. In necrosis, you see a lot of times the cell is ruptured open. You will see no nucleus. Yes, you will see no nucleus. But to see a pycnotic nucleus is very unlikely in necrosis. Okay? So that's why this one ends up being C, apoptosis, versus necrosis. Because these are the two ways that you can have cell death, if you remember. Okay? And you can see that here. Apoptosis versus necrosis. And we discussed last time, why is it that you have cellular swelling at the beginning, but at the end you have cellular shrinkage? Can anyone tell me why you have this change from cellular swelling to cellular shrinkage? Why do you have that change? So the reason why is because if you remember, you have blebbing that goes on. So as this cell blebs out, these blebs get eaten up by macrophages. So the actual cell itself becomes smaller or appears as cellular shrinkage. And that's the basis on why the cell is originally, swollen, but starts to shrink with apoptosis. All right, good. Now, here is another question that has to do with repair. So it's a microscopic examination of the wound is most likely to show which of the following. So this person has a 5 days after sustaining a forehead laceration. The wound is clean, it's dry. You see pink granulation tissue. You're going to see, angiogenesis with type 3 collagen because you have granulation tissue here. So this is around 3 to 10 days post-injury. Okay. Macrophage and fibrin clot degradation. This is something that you would see more towards the 1 to 3 days. This here, with capillary dilation and neutrophil migration, this would occur on day 1. Acellular tissue with type 1 collagen fibrosis. What does that sound like to you? Acellular tissue with type 1? Yes, a scar or fibrosis. Fibrosis. Now, fibrosis is weeks in advance, right? It's a lot of weeks ahead. Now, pink granulation tissue is equal to type 1, moving to type 3. So that's the reverse. It's type 3, and then it becomes type 1 when it's fibrosed. Okay? So that's the general breakdown. Because type 3, you got to think, is the type 3 is blood vessel.
Doc, that was for answer A. When I saw pink granulation, I was thinking, well, I chose A. It's shifting from type 1 to type 3. That's what I was thinking for A. Is it wrong?
So why are you saying typing like so type 1 to type? How are you switching from type 1 to type 3? Explain that.
Did I say it right? Okay. Which one is more? Which one is more stronger? Type 3.
Type 1 is the strongest.
Thank you. Okay, I said it wrong, then. I'm sorry, Doc.
Okay. Yeah. So you have type 3, which
yes.
is blood vessels in the granulation tissue, and then it becomes type 1.
Thank you. I'm sorry. I said it wrong. My apologies.
Yeah, no worries. That's why we go over this, right? So you can kind of make sure that you remember and kind of clarify those misconceptions.
Okay. Thanks, Doc.
Yeah, no worries. And then fibroblast hyperplasia with disorganized collagen deposition. What do you think that is? What is that? Yes, it's a keloid. If I said organized collagen, what would you say? Hypertrophic scar. Good. Now, if I was to now say, what collagen do you expect to see in a keloid? What would you say? 1 and 3. Perfect. Hypertrophic scar, only 3. Good. All right. Nice. Now, here in this question, we're essentially asking for the most likely underlying mechanism of these findings. Why is it that the cells appear pale, swollen in the PCT? Why do they become swollen? It's the sodium potassium ATPase pump, right? So you decrease if you decrease sodium out, you have a buildup of sodium inside. So water falls in and the cell then swells. So that's why B is the right answer. Now, let's continue. So now, which of the following surface area is most likely to be found on the cells indicated by the arrowhead? So these guys here are called giant cells. Okay. These guys are my little sweetie, my little daughter. These guys are called giant cells. Okay. So essentially what giant cells are is macrophages that have fused together into one giant cell. That's why you see multiple nuclei inside the cell. Okay. Now, what is the cause of this? TNF alpha and interferon gamma. Okay, but TNF alpha is the big player. Now, so what do you expect to see surface receptor wise or surface antigen wise is CD14 because that's part of the LPS toll-like receptor. What's another CD marker that you could possibly see on there? Another CD marker you could possibly see on a macrophage. Other than CD14. Maybe CD16? And what's one other marker? The last one is CD40. That's why this isn't the right answer. Because you see ligand here. This is on TH1/2 cells. Okay. Any questions on any of that?
Question, Doc. I know you mentioned to me about the tumor necrosis factor when the giant said, okay, we have TB, macrophage, order to signal more, you have TNF alpha, interferon gamma. Is the expression of more TNF alpha is why we see cachexia in TB patients,
Yes.
or no?
So you have the high levels of TNF alpha, right? And that can present with cachexia. Because if you remember back when we talked about cancer cachexia, the two main things that cause cancer cachexia is IL-6 and TNF alpha.
Yeah.
Okay.
Okay.
So that's why you get the weight loss in someone with TB.
Okay. All right. Thanks.
So they can even go further and they could ask you then, is this due to atrophy? Is this due to an increase in basal and metabolic rate that they have this weight loss? Is it due to decreased calorie intake that they have this anorexia? Which one of these is the reason why cancer cachexia happens?
Well, that's good. Okay, I didn't know that. Okay. All right. Okay.
So cancer cachexia, IL-6 and TNF alpha, the way they work is they increase basal metabolic rate. They cause you to burn more.
So that's why we give patients that medication to help them prevent body wasting. And okay. That's what it is. We give all in pharmacy, we give them all these dots connecting. I didn't know like that's the reason why. We know that they encounter wasting, but the patho behind it, I never knew.
So what drug are you talking about?
Like, okay, like we treat patients in the oncology ward, right?
Yes.
We give them this medicine that increases appetite.
Yes.
So now I see why, because of this ideology, this patho that I never knew this side of the coin. So
Yes.
the IL-6 and the tumor factor alpha are increasing basal metabolic rate. So they're burning through it. So
Yes.
we need them to take in more calories.
Yes.
Ah, okay. All right.
Yeah.
All right. I like that.
That's
Thanks,
exactly
doctor.
why you give them things that increase their appetite.
Yeah.
Yep, yep, yep. Okay, good. All right then. Any other questions before we move on? No. Now, the other thing is the wasting that you present with is very particular. For instance, you waste at muscles that you don't normally waste at. So, for instance, like your temporalis muscle that deals with jaw movements and chewing, this muscle you hardly ever see waste away unless the patient has cancer cachexia. So that's a big clue for that. Is this muscle right here on the side of your temples, right? That goes out whenever you're chewing. If this starts to waste away, you got to be like, something's going on here. I'm very concerned that you got cancer cachexia. Okay. Yeah, I don't know what megase is. I'd have to know the actual
Oh,
like the actual mechanism name.
yeah. All right. Oh,
Okay,
sorry,
okay.
doc.
It's
Yeah. Sorry about that. Sorry about
no,
that.
no,
Yeah.
that's good. But that's what essentially you're doing.
Yeah.
Is you're trying to increase your appetite to fight off this increased basal metabolic rate. Okay.
Oh, that is
Great.
awesome.
Okay. So any other questions before we move on? No? All right, good. So here is the next question that we're talking about. In this example, we're essentially just saying this patient's contracture is most likely due to activity of which of the following cells? Myofibroblasts. We've gone over that. I'm not going to harp on it anymore. This one we haven't done yet. So I'm going to take my time on this one. So this has to do with which of the following best describes the most likely underlying pathophysiology of his dyspnea. So why does he have dyspnea? So this patient has dyspnea because this person has an MI. Due to the MI, he has fluid being pushed out, which is why he presents with a frothy sputum. Now, with that being said, you got to remember when you get edema, you get two different types. One is due to a transudation. The other one is due to an exudate. Okay? Transudation is due to what? What are the causes to lead to transudation? Yes, increased hydrostatic pressure. What else? Decreased oncotic pressure. Great. All right, perfect. Now, an exudative is usually due to inflammation from infection slash trauma. Okay. So, an exudative, you get immune cells. In transudative, there are no immune cells. Now, if you have someone who has a heart attack, here's my heart, and we have an issue pumping out. Therefore, blood pools in behind. Okay? And goes to your lungs, increasing the hydrostatic pressure, leading to a transudation. A. So that's why that's the answer. Now, let's talk about the other guys. Localized constriction of pulmonary vasculature. What is that they're talking about? This is essentially, if you go back to lung physiology, VQ mismatch. This is VQ mismatch. So essentially what's going on here is that the area has hypoxia, which is why you have constriction of the vasculature, therefore decreasing blood supply to that area. Now, if you constrict here, what's the pressure here? Does it go up or go down? It goes down. So that is why VQ mismatch does not lead to edema. In all honesty, a VQ mismatch helps edema resolve. Because by decreasing hydrostatic pressure, you allow more fluid to leave, enter back into the blood, and go through the veins. So you increase reabsorption. Well, not really reabsorption, but absorption. Okay? Now, the next one, bacterial inflammation into the pulmonary parenchyma. This is a exudate because it's a bacteria. Acute obstruction of a pulmonary artery segment. Same thing. If you block here, everything back behind it goes down. Increased permeability. This is an exudate. Elevated capacity of the pulmonary lymphatic system. This would decrease, not increase edema. Because edema essentially is due to a few things. So here's my block. And here's my fluid. Okay, this is the extracellular fluid. Now, pouring into this is your filtration. Now, there's various things that affect filtration, like we discussed. Increase hydrostatic pressure, decrease oncotic pressure, and then out of the ECF is your lymphatics. This is an equilibrium. Okay? So whatever you filter leaves via the lymphatics. This is the positive filtration. Okay? I'm not incorporating what you reabsorb or what you absorb back into the system at the venous end of the capillaries. I'm not accounting for that. I'm just accounting for the net filtration here. Now, whatever you filter out goes into the extracellular fluid and stays in that space. And then in the lymphatics, you drain it. Okay? Now, this, if you increase, causes the extracellular fluid to drop in the tissues, so you improve edema. And that's essentially what goes on. Okay, good. So let's keep moving. So that's the last one with our question bank. So now, anybody have any questions on any of that stuff before we zip on through the rest of this, because we've talked about these guys mainly already. Any questions? before we go through these rest of these necrosis? No? We're good? All right. Let's finish this off. Let's end strong. All right, so fat necrosis, we already essentially discussed it. Okay? You have fat necrosis because enzymes break down fat, releasing triglycerides that then get activated by calcium. Okay? Via lipolysis or saponification. Okay? Now, with that being said, how does that look under a microscope? Calcium looks basophilic. Okay? So you'll see areas of basophilic infiltrations when you have fat necrosis. Now, just like I said earlier, injury to the breast and pancreatitis. Okay? Now, fibrinoid necrosis, we discussed already. This is what it presents with. Now, another way they could say is this is hyaline not hyaline arteriolosclerosis, but hyaline proteinaceous material. Okay? This is another way they could say the exact same thing, hyaline proteinaceous material, or fibrinoid necrosis, or they can say eosinophilic instead of hyaline. They're all essentially the same. Okay? Now, gangrene. Remember, you have dry and you have wet. What is the thing between them that connect them? Neutrophils. Causing positive liquefactive necrosis. That's the leading portion between the two of them. And just like you see, super infection just means that on top of this necrosis, you get an infection on top of it. That's what super infection stands for. Okay? Which is why you get wet versus dry. Okay? Wet is due to neutrophils coming to the tissue, dying, forming pus. Good. Now, accumulations. We already talked about dystrophic versus metastatic calcification. We already talked about those two. Now, which one is trauma-based? Yes, dystrophic. Good. Where do you find metastatic calcifications? Mainly. Three organs. Organ 1, organ 2, organ 3. Lungs, kidney, stomach. Because if you remember, these are the three places that you have increased pH due to that alkaline tide. And since you have higher pH, it's more likely to calcify. Good. Now, we already went over this, so I'm not going to harp on it anymore. You can see once again, this is secondary due to necrosis. This is due to anything that has hypercalcemia. When you look on a microscopic image, you see basophilic again, because that's what calcium appears as. Yes. And then here you see kidneys, stomach, and lungs. Okay, good. Lipofuscin. Remember, we discussed if you see brown pigment, if you see a cell and you see brown pigment inside, it can only be two things. One, iron. Two, fat peroxidation, also known as lipofuscin. How you differentiate between the two of these? What stain do you use? Yes, I mentioned the stain. Prussian blue. Prussian blue stains iron blue, while lipofuscin stays colorless or brown. Okay, so you see this? Once again, this is wear and tear. You mainly find this in the heart and liver. You can find it other places like the colon, kidneys, and eyes, but heart and liver is usually where they go after, because these are also the areas that can get iron deposit in them. So they love using those guys. And this is due to lipid peroxidation, due to increased free radicals that we discussed back in PATH. Now, amyloidosis is something we haven't really discussed so much about, but this is basically abnormal aggregation of proteins. Okay? Proteins get abnormal, they deposit in various tissues, which is known as amyloidosis. Now, there's two different types of amyloidosis. There's primary amyloidosis and secondary amyloidosis. Secondary amyloidosis is due to chronic conditions or chronic inflammation. Because if you remember, IL-6 increases acute phase reactants, and one of these acute phase reactants is amyloid. So that's why people who have chronic infection or chronic inflammation can get secondary amyloidosis, which is different than primary amyloidosis. Now, the way you diagnose them with amyloidosis is you do a Congo red stain that you look under with apple or polarized light. So it looks like this, apple green. Okay? And that's essentially what's going on here. Now the tissue biopsies that you use for this, majority of the time, is your abdomen / tongue. Those are the areas that you usually biopsy to see if someone has amyloidosis. Okay? Now, that finishes it. We're done. Those are all the intracellular accumulations on the pathology portion of it. Now, I did not rehash glycogen, because glycogen is also something that can be intracellular, right? You do a pass stain for glycogen. We talked about iron. We talked about it could be fat, so lipids. That you stain with Sudan oil. Okay. So that is something that you can also utilize with lipids if you wanted to see if it was a lipid. Let's think here. What else? What other intracellular accumulations? I want to say that's it that you have to worry about. Amyloid, calcium, lipofuscin, iron, amyloid, glycogen. Yeah. All right, guys, let me stop this recording.